Dear colleagues, today I will present to you a case of duodenal atresia. Duodenal atresia is the most common congenital atresia of the small intestine. It has a prevalence of 1 in 5,000 births. From an ultrasound perspective, the hallmark sign of this anomaly is the so-called double bubble sign, an image caused by the dilation of the stomach and the proximal segment of the duodenum. This sign is present starting from 24 weeks. However, in some cases, it can also appear earlier, around 18 to 20 weeks. Another characteristic ultrasound finding of duodenal atresia is polyhydramnios, which is present from the 24th to 26th week. As for associated anomalies, duodenal atresia is associated with chromosomal defects in 30% of cases, mainly trisomy 21. And in about 10 to 20% of cases, it can be associated with cardiac, renal, and vertebral defects. The case under examination concerns a patient who came to our attention at 22 weeks and 3 days due to the finding during the second trimester screening of the characteristic double bubble image. The assessment of the amniotic fluid is performed both by calculating the AFI, which turns out to be 19 centimeters, and by measuring the maximum pocket, which is 75 millimeters. Therefore, in both cases, MH at the upper limits, though still within the normal range. At this point, it is of fundamental importance to rule out possible differential diagnoses. Specifically, the differential diagnosis should be made with choledochal cysts or hepatic cysts. But in this case, there would not be communication with the stomach, which I am showing you here in the clip and is clearly visible. Furthermore, the liver appears perfectly normal and the gallbladder is completely regular and clearly visualized. The other fetal anomalies with which duodenal atresia enters into differential diagnosis are duodenal stenosis, where the site of obstruction is generally at a more distal level, proximal atresia of the jejunum, in which we should see dilation of the entire duodenum and the proximal jejunum, intestinal volvulus, where there is dilation of the entire small intestine, and duplication of the proximal intestine. In this condition, however, the stomach appears normal. And finally, annular pancreas, with which there are no substantial ultrasound differences. Given the high risk of association with Down syndrome, during the examination, particular attention is paid to investigating those specific features of trisomy 21 for which the patient had undergone first trimester screening with nuchal translucency ultrasound and NIPT, both of which were normal. Therefore, the fetal profile and the nose are carefully examined, both of which are found to be normal, as well as the nuchal fold, which is also normal. A study of the fifth finger on both hands is performed to rule out the absence of the middle phalanx of the fifth finger, a sign often associated with Down syndrome. In addition, the shape of the head is evaluated by measuring both the biparietal diameter and the occipitofrontal diameter in order to rule out brachycephaly, which is also a characteristic sign of Down syndrome facies. A complete echocardiographic study is performed, which is normal, and the examination of the remaining fetal anatomy and fetal biometry are also normal. Let's move on to the management of the case, which requires a detailed ultrasound examination, including an echocardiographic study, which was performed, genetic counseling with a study of the fetal karyotype. As for monitoring, an ultrasound follow-up every 2 to 3 weeks is necessary to monitor growth and assess the volume of amniotic fluid. A pediatric surgical consultation is required for the couple. Finally, regarding the risk of recurrence, it should be noted that in isolated cases there is no increased risk. Thank you for your attention.